Hi students, this is Dr. Tatum. Today we're going to talk about Chapter 7, which is nursing care of the family during pregnancy. So if you'd like to take out your PowerPoint slides and follow along, we'll start on slide 2. I also think it might be important to have your textbook available because I will be referring to different page numbers in your textbook that will aid in your understanding of the content. So this first slide that we're going to talk about is just the prenatal period in general. So really, this is a time for change. So both physical and psychological preparation are taking place for birth and also for parenthood. So kind of a wide array of emotions taking place for both mom and for dad. Also, wide emotions for any siblings and also grandparents. So it is a very special time, but this is the time that a woman will start to think about prenatal care as well. And so what I want you to do, I just want you to take a few seconds to reflect on prenatal care and the value of prenatal care. Why is prenatal care emphasized in our culture? And why is it stressed throughout pregnancy? So I just want you to think about that question for a few seconds. Really, prenatal care is so important because it helps the practitioner. So it could be a doctor, it could be a nurse practitioner, it could be a midwife that's examining the patient. But it's important for that practitioner to conduct a comprehensive exam, do an intake of their history, but also really reflect on if there are any pre-existing conditions that the patient might have. So it's a time for a diagnosis and also treatment of any pre-existing conditions that could affect mom during the labor process. And also it's a time for us to monitor the status of the baby. How is the baby growing? Are there any anomalies that can be found on ultrasound that could affect the delivery process? So that is why prenatal care is emphasized and stressed throughout pregnancy. We're going to move on and talk about slide 3. Slide 3 is a general discussion about the span of pregnancy. So pregnancy is 9 months and it's divided into 3 trimesters. So you can see here the first trimester are weeks 1 through 13. The second trimester are weeks 14 through 26. And the third trimester are weeks 27 through 40. And remember, a term pregnancy, that definition of a term pregnancy is when pregnancy gets to at least 38 weeks gestation and it ends between 38 and 42 weeks gestation. So that is a term pregnancy. So just go back and review those definitions that we talked about in chapter 6. In chapter 6, we also talked about the signs and symptoms of pregnancy. And I referred you to page 172 in your textbook that really goes through these different indicators and also stresses other possible causes of presumptive and probable indicators. And so as you look at table 6-2 in your book on page 172, you can see that there are other possible causes in relation to the presumptive signs of pregnancy and the probable signs of pregnancy. However, once you get to the positive indicators, such as hearing the fetal heart tones, actually seeing the fetus on ultrasound, or even palpating the fetal movement, all of those things are positive indicators, and there are no other causes of those things. And so that is how pregnancy is actually diagnosed. Those are those positive indicators. Presumptive indicators like amenorrhea, nausea, vomiting, breast tenderness, just feeling so fatigued, all of those are early signs and symptoms of pregnancy. However, each of those symptoms could be caused by something else. Probable indicators are positive pregnancy test, the Goodell sign, Chadwick's, and Hager sign as well. But again, if you look at your chart, there are other possible causes of these things like pelvic congestion. And so we can't make an accurate diagnosis of pregnancy until we hear fetal heart tones, until we can actually visualize the fetus, until that fetus can really be palpated by the practitioner. So just make note of that. I think that's important. All right, as we move on, slide 5 talks about different terminology. So estimated date of birth is known as EDB. Estimated date of confinement is known as EDC, and estimated date of delivery is EDD, and they all mean the same thing. So what is mom's potential due date? And so what we do is once we figure out the first day of her last menstrual period, we use Nagel's rule to calculate an estimated date of delivery. And so you can read here what Nagel's rule states. We first determine the first day of her last menstrual period, subtract 3 months, add 7 days plus 1 year, and that can give us an EDD. Otherwise, we can add 7 days to the last menstrual period and count forward 9 months, which is another way that you might see some practitioners do this. What I'd like to do is give you a few dates, and I want you to try to calculate the estimated date of delivery. So the first date that I'm going to give you of the first date of her last menstrual period would be July 10 of 2020. I want you just to calculate the EDD. July 10 of 2020. So those of you that calculated April 17 of 2021, you are correct. I'm going to give you another date. So just thinking about today of her, if the first day of her last menstrual period was in fact today, so 3/30 of 2020, I want you to calculate the EDC. Those of you that calculated December 6th of 2020, you are correct. So here, because it's March, we know that pregnancy is 9 months. So 9 months from March is December. So we don't actually have to add a whole year here. So just make note of that as well. All right, we're going to keep moving on. The next few slides talk about adaptation to pregnancy for both the mom and the dad, and then it also includes siblings as well as grandparents. I want you guys to read through this on your own. This is pretty straightforward content, and it's interesting as well. So take a peek at that after you get done listening to my lecture today. We're going to move on and we're going to talk here on slide 8 about just care management. As we talked about before, prenatal care is done to determine pre-existing conditions and also treat those conditions so they don't interfere with the labor process. There is a lot of emphasis placed on preventative care and optimal self-care during these prenatal visits as well. The women that usually seek prenatal care are those of higher socioeconomic status or even middle socioeconomic status. Those that have a lower socioeconomic status might have barriers to prenatal care that can prevent them from receiving adequate care and also can be linked to just higher infant mortality and higher maternal mortality rates as well. So that's unfortunate, and that's something that we're going to talk briefly about here. So those women that live in poverty-stricken areas, they may not have access to public or private health insurance. And also there might just be some sensitivity with just different doctors within their area. If they're from a different culture, they might feel that the doctors within their area might be very insensitive to their culture. And so that can harbor that mistrust and make them not want to seek prenatal care. Also, there might be barriers to communication. And a lot of times, research has stated time and time again that those women that don't seek prenatal care have a higher chance of having a baby with a very low birth weight, so less than 2,500 grams. She may have a higher rate of preterm labor and just higher rates of, again, infant and maternal mortality. And so, again, it's very much stressed that prenatal care needs to be in place, but trying to figure out how to get adequate prenatal care seems to be an ongoing struggle. Some of the different barriers that you're going to read about would be just lack of transportation. Maybe they don't have enough transportation to actually get them to their prenatal appointment. Also, unpleasant facilities or procedures, inconvenient clinic hours, and I think this is huge for women that work full-time hours and they don't have enough time off. A lot of times they see these prenatal appointments as more of an inconvenience to them because it requires them to take time out of work to get to the clinic when they're open. If these clinics close by 4 or 5 o'clock in the afternoon, then these women cannot get in to see their doctor. Childcare problems is also unfortunate. You know, some women, if they have dependent children at home, they're not able to take those children with them to their prenatal appointments. And so they might see that as an inconvenience to them as well, and that's why they don't go. There's also personal and cultural attitudes, and then just the inadequate number of providers, which is true. Nowadays, there's more and more nurses that are getting their advanced practice degree as a nurse practitioner, and nurse practitioners are actually helping in this area where they're collaborating with many, many physicians, and they are taking prenatal care patients under their wing so they can start assessing them and giving these women adequate care. All right. Other things to think about. A lot of times that initial visit happens during that first trimester. Usually the middle to the end of the first trimester is when most physicians like to see their patients. But usually that first trimester is when they conduct that very comprehensive assessment. It can be lengthy, and we're going to talk about what comes about in that initial visit, but it can be lengthy. But during that first trimester is when they are first seen by their doctor, and then they're seen monthly until about 28 weeks gestation. After that, they're every 2 weeks until about 36 weeks gestation. And then that last month, they're usually seen weekly by their doctor. So you can see this westernized approach to prenatal care is pretty rigorous, where we are meeting with our physicians very, very routinely, and they are checking and assessing us to make sure that we don't have any pre-existing conditions like diabetes or gestational hypertension, or just hypertension in general that could cause complications for us during labor. All right, so moving on to the interview. This is when we really figure out the patient's reason for seeking care. So maybe this is all the presumptive signs and symptoms that we've discussed. So maybe they haven't had their period. Maybe they're noticing more nausea and vomiting. Maybe they're really, really fatigued. So maybe those signs and symptoms of pregnancy are presented here at this initial visit. So just finding out her particular concerns is really important. And then we really conduct a comprehensive health history on our patient. So finding out about her current pregnancy is important. Past pregnancies, how many, what they were like, any complications. Just figuring out more about her family history in general is also crucial. Taking an intake of her psychosocial history and doing a physical exam are all part of this initial interview and visit. There are lots of diagnostic testing that we're going to go through in just a minute here on the next few slides. So we'll talk more about that. Getting a complete obstetric and gynecological history is also very important. So thinking about obstetric history, things like the age of her first period, so the age of menarche. What is her menstrual cycle like? Does she have any complications? Has she had a history of contraceptive use? Has she had any infertility problems? Any history of sexually transmitted infections? Does she have a recent pap smear done? And if not, then a lot of times the doctor will go ahead and do a pap smear at that initial visit. And this is a time for the doctor too to really establish the first day of her last menstrual period and to establish that estimated date of delivery. Nutritional history would be important to really ask about just because we worry about dietary practices. What is her intake like? Does she have any